and then start webinar. Okay, and then, all right, good. We have some people joining. Okay, and I've got one more button to press before we can start. Okay, I think we're good to go now. So welcome everyone to our 4th episode of Growing Stronger's Achondroplasia. Today we are here with the Dr. William Mackenzie, Department Chair of Orthopedics at Nemours Hospital in Delaware. And I'm pretty sure everyone who's joining us today has a pretty good idea of who you are, Dr. Mackenzie, as most people within the dwarfism and skeletal dysplasia community. But for those maybe who don't know you, can you tell us a little bit about yourself?
Well, that's a long story. I'm getting old. Well, I grew up in Canada, and I trained partly in Canada and partly in the United States. And I came to this institution in 1993 from Vancouver Children's Hospital there in British Columbia. And I've been here for about 30 years. I've been a very lucky person in that I had tremendous mentors. Most of them were actually geneticists that trained at Hopkins under 𝘾𝙊𝙉𝙍𝙍𝙍. And I've had the opportunity to have a great life as a surgeon, working with the team, taking care of people with all different forms of skeletal dysplasia.
Can you tell us a bit, like, what kind of piqued your interest or what led you to specializing in skeletal dysplasia?
Well, as I mentioned, I had some mentors who were geneticists, and I started with Charlie Scott, and also a surgeon I worked with, and Judy Hall and Dave Lemoyne and Rich Pauly, and all became good friends over the years. And they taught me a lot about skeletal dysplasia. I'm a surgeon that has an interest in the physiology and development of various disorders. And that drew me with the genetics into skeletal dysplasia. And I've always worked in institutions that have had a strong relationship with people with skeletal dysplasia. And it just became an area where I felt very, very comfortable in. And I enjoyed the patients, and I enjoyed the families. You know, I had an amazing opportunity to meet many children soon after they were born, and I still follow them to this day. You know, I have many patients who, you know, obviously graduated from high school and college and got married and had kids, and I take care of the kids now. So there's not too many areas in medicine where you can do that, actually.
Right. It's like you're part of everyone. I know you're part of like everyone's family in a sense. Like you're, I would say, considered a family member to many families. If I had to guess.
Excuse my occasional grumpiness.
Well, so knowing your, long career that you've, had over the years, obviously there's been a lot of change over the past decade, I would say, within achondroplasia and all, new research and everything happening. There now is Voxogo available for those in the US and Europe. How has it for you been like to, kind of be in the middle of all of that, and how, and I know I listened to, I think, a podcast you were interviewed on a few months ago. I think you started at Nemours in 93, is that correct? That's the year I was born. And so, and just knowing my own personal experience, or, my own personal timeline, I know FGFR3 was discovered in 94. And so, we're on 27 years now, and it's only been recently, within the last decade, that we've had this huge, involvement in other treatments, besides surgical, for achondroplasia. And so I know many are just, I'm sure, curious to know kind of like what has it been like to sort of be in the middle of all of that, and being in like the involvement or evolvement in that process.
You introduced that very well. No, I'm serious, because people don't understand how recent this evolution has been. In your lifetime, we've gone from thinking about, like seriously, in the 80s, well, really the 70s and into the 80s, there was sort of achondroplasia and pseudoachondroplasia and the others, It was really, really interesting. And today, actually, everyone says we've identified 450 different types of skeletal dysplasia, and that number is actually shrinking, because we're starting to understand how some types of dysplasia are related. But over 400 different types of disorders affect our skeleton, and probably close to 400 by now have an underlying genetic basis. And almost every day, new diagnoses or new understandings appear. And this is partly to do with the evolution in the understanding of how our genes work. And, the simple idea of Mendelian genetics, where, you get two dominants together, a dominant recessive or two recessives, there are so many other ways to think about how we transmit information from parents to children. So it has been absolutely dramatic. And we've gone from barely understanding these disorders to fully understanding their impact on the skeleton, and then made the step of initiating treatment. And, we have Voxogo available to us now, but as you know, there are many, many other drugs coming down the pike. And it's going to be very confusing and very difficult for parents to understand which ones, and it might be that the insurance or the cost or the availability, like if you live in Somalia, I don't think you're going to be getting, but you're going to be able to get a prescription for Voxogo. Honestly, I've had maybe 4 or 5 families write me from, Guatemala, Chile, wherever, hoping to move to the United States so they can get a prescription and give this drug to their child.
I made a mental note to myself before coming on here, because I know, and you mentioned earlier, you're originally from Canada, and I personally, and I've seen on Facebook, there have been a lot of families in Canada who are going through that right now of how can they access it? And I think, it has to be so hard on them because, Canada is just like our upstairs neighbor, basically. And so for it to be available here and approved in the US, and they can't get it whatsoever, it's really hard to watch that. And I'm
Canadian drug enforcement system, drug management system is just, it's following in lockstep with the FDA. So it's just a matter of time. I think the biggest challenge in Canada, and I'm not sure, now remember, I'm a Canadian, but I've been living in the US for 30 years. And so
right.
I'm in Canada.
Right.
And, I think that in in Canada, there might be more economic challenges. And so, for example, for the MPS enzymes, there are several groups that work together with the government to negotiate prices for treatment of children. And I'm sure that's what's going to happen with with Voxogo as well. And so there may be a little bit of delay, but it won't be significant. But you're right, it's hard, because these educated families are sitting in Toronto or Vancouver or wherever, and they're thinking, well, I'd like to get that for my child. And there'll be a time when it won't be too far off when that's available.
Right. Well, speaking of, I think that, of that, and, knowing your background is orthopedics as well, I think we've done enough kind of like genetics overview. But I know we still have a lot of questions kind of pertaining, to all these new developing research. How do you, feel if or like these therapies will help when it comes to spinal stenosis?
Well, of course, to be really honest, there are a lot of things that treatment can do. And my hope for Voxogo is the impact on spinal stenosis. And so that relates to the size of the foramen magnum, which relates to apneic episodes and sudden death syndromes in young children. We know that the biggest impact on the lives of people with achondroplasia is spinal stenosis. And it's wonderful that we can get height out of it too, but to me, it's secondary.
Yeah.
And so there is absolutely no information about its impact in this area. We would expect that if the drug was given very early in life, first day in life, that there should be an impact on spinal canal growth. But we just don't know what that is. There is a study going on right now that they're looking at volumes and sizes of the spinal canal in a very young group. It's a small study, and it will help us understand this. But that's my hope for this drug in the future, is its impact in this area.
And you kind of answered it, but my next question was, do you feel there's a bigger benefit if it is, because I know in the US it's approved for 5 and up, but can you get a bigger benefit if it is started at age 1 or 2 years old? And this question also kind of is more about height though, but would the potential gain in height be greater if the drug was used for a longer period of time, and does it help with other potential health issues related to achondroplasia?
That was about 14 questions.
I know. I have it listed on one line, but it's technically 3 questions in one bullet point.
Let's start with one of them anyway. So we know the spinal canal does grow. Most of its growth occurs very early in life, the first couple of years, first 2 to 3 years of life. There is some growth after that, but the real impact is early on. And so from what we know about the growth in the spinal canal, giving it in utero or in day 1 would be ideal for that, right? And also, babies triple in size in the first year. Average stature babies triple in size in the first year. So during that growth period, if you have the drug on board, which is restoring close to natural growth, then it would be a huge impact. But we know that from the trials, certainly between 5 and 10, there's been an average of about 1.5 centimeters of linear growth over average. But we don't know too much about before and after that. But certainly there will be an impact. We know that. And I think it benefits, the height and the growth of the spinal canal, the earlier you start.
Mm-hmm. And I think you did just answer this. And would the potential gain in height be greater if the drug was used for longer period of time?
Well, we think that,
Mm-hmm.
but we don't know that yet. You know, we
Right.
know over the time it's been studied, it has an impact. But what you have to remember, I was just actually looking at some of the curves in the most recent paper, but you know, some people are non-responders. Some people don't respond very well to the drug.
Mm-hmm.
Some people respond really well. There may be a difference in the sex, gender. So we don't know what the long-term impact is going to be, but certainly in the average growth of the group that was studied in the phase 3 trial was 1.5 centimeters more than expected per year. So if you look at that for 10 years, that's a lot of height.
Mm-hmm. So knowing that age plays a role in this, and this is coming from a parent, so not me directly, but from a parent, I'm wondering,
I see the questions coming up in the question box, and there was one just a second ago. Did you see it?
Yes. So we had one in the chat and in the question box. I think they were the same one. But we also have more we do have more in the chat box, and I will start with those. But the first one that was in our Q&A box is, when will Voxogo be available for newborns? And I'm assuming that person is in the US because they did not specify, but overall, I guess, when will Voxogo be available for newborns is one of the first questions.
Okay, so in Europe, it's from age 2 to closure of growth plates. In the US, it's 5 to 18. It will depend on when the phase 3 trials are finished in the younger age group in BioMarin, and I should know that date, but I don't know that date. And so the FDA has been a little more aggressive recently, but they're still very slow and careful. And I would think it's going to take a number of years until we get that ability to move it down. It can be given off label. You can write a prescription for it off label, but you know, you're responsible for that child.
And I think we did discuss this earlier, but just so the person that submitted it knows it did get answered. Do you suspect that Voxogo will help with spinal stenosis and curvature at all?
Curvature, we don't know. It's sort of like, if your legs grow faster, will they grow straighter?
Mm-hmm.
You know, we don't know the answer to those questions. I don't think that if you have significant thoracolumbar kyphosis, that Voxogo should straighten that out. But I don't think we know. I mean, I could give you some theoretical reasons why or why not, but I basically just don't know. Hi, Manera.
Hi, Dr. Mackenzie. How are you?
Good.
Thank you. Yeah. My reception is patchy, which is why I've handed the baton to Chandler for today.
Okay, good. Keep her moving.
Are there any concerns regarding lower bone density with increased growth with Voxogo?
So in achondroplasia, we usually do not see low bone densities. There are a few skeletal dysplasias, like, for example, metatropic dysplasia, which is definitely associated with low bone density, and we see long bone fractures in those kids. But I'm just out of interest, I've taken care of a few kids, maybe 3 kids with tibial fractures who have achondroplasia, but it is a rare event. I mean, that's probably in thousands of kids with achondroplasia. So my guess is probably not, as long as nutrition and vitamin D use is appropriate.
Again, on Voxogo. So Voxogo hasn't yet been approved for children under 5 in the US. What's the impact of not being able to start Voxogo until age 5?
Well, your impact, we think the impact on spinal stenosis will be limited, and the height opportunity is less.
And kind of going back to what you mentioned a few minutes ago about some not responding well to it, what are the theories or reasons, I guess, for why some are not responding well to it?
Oh, I wish I could tell you that. Maybe if I was a geneticist, I could hazard an opinion. But basically, you have one good gene and one not good gene if you have the achondroplasia. And we know the phenotype does vary, right? We have kids who are much taller. We have kids who have very obvious changes of achondroplasia, and other less so. There are many things that could impact this.
Do you think any of the other drugs, that are coming up behind will be able to increase growth faster? The person says that they're hoping for around 1 inch per year, I guess.
Oh, well, what they're hoping for and what is possible are two very different things. I don't think, first of all, we have no evidence yet. There are very different. There is drugs like Voxogo, which have a longer half-life, which will mean, a longer interval between injections. We probably don't expect much difference with those drugs, but some of the FGFR3 receptor drugs may be an improvement. I don't know. I don't think anyone knows that.
Mm-hmm. With the current body of knowledge, should doctors be more aggressive in prescribing Voxogo off-label for age purposes in the United States?
Well, that puts the child and the family and the physician at risk. Mm-hmm. And I think that, we can feel maybe a little bit more comfortable that the European Commission allowed it down to age 2. But be a little bit careful in the United States.
Will there be any complications combining Voxogo or any of the other drugs in the pipeline with limb lengthening procedure?
No, and I think that's an opportunity. I was with Dr. 𝘾𝙆𝙉𝙍𝙍. We were in Spain together, and he and I have known each other for a long time. And Dror gave a very good talk. Basically, the future of height in achondroplasia, and I thought it was well done. He talked about the fact that, boy, won't it be easier to attain close to average height with a lowered surgical impact. So you get part of the way there with Voxogo and limb lengthening on top of that, for those that want it. Many people don't want that sort of height. But
right.
For you, it will be an opportunity to get there with less complications. So an interesting idea. As far as we know, should be no impact there.
Mm-hmm. And I know, so we had Ravi on 2 episodes ago, and that someone had asked him that question as well. And I think he had said, I'll have to go back and watch, but he had said, because there are some families that we've been seeing in some of our parent groups who have started taking Voxogo while either like immediately after kind of going through the first lengthening or in coincide. And I think Ravi had said I don't want to quote him, so this is a plug for people to go watch our episode with him, because I don't want to like mess up his quote. But I believe he had said, you know, if you're going into this knowing that you're interested in doing both of these treatment options, why not start with this first to see kind of how much height you get from Voxogo alone, and then I think decide later on if limb lengthening is something you know you want to do after you've kind of gone through the entirety, you know, once your growth plates have closed and you know you can't take it anymore.
Well, I think that's a sage comment.
Mhm.
I think it's a good thought. It sort of depends on the age of the individual, I think.
Mhm.
No, we're not lengthening, or I don't lengthen.
Yeah.
But the good places aren't lengthening 5-year-olds, right?
Mhm.
And I think that when, you know, a lot of people consider starting around age 8 to 10, that seems to be a number around the world now. It would be perfectly reasonable to start Voxogo at the time when it's legal in your country, and see how it goes. And if it looks like the trajectory is going to put you where you want to be, then wonderful. And if it doesn't, there's that opportunity while you're continuing with the Voxogo in an older age. So no, I think that's a good thought.
So we had 2 new questions come in. The first one, have you seen any benefits such as improvements in mid-phase hypoplasia or leg bowing in the Voxogo trials?
No. As far as leg bowing, no. There is a suggestion that body proportion may be improved, upper to lower body segment proportion. The most recent study suggested there may be an impact there, although there is some discussion about the way that data was analyzed. What was the last part? You said there were 3 parts.
Well, the next question was, are any drugs showing improvement in arm length?
Well, that's basically applies to the upper lower body segment. And so, yes, there are some subtle suggestions that it will have an impact. You know, something I'll introduce here, which may be a little bit confusing, but the impact in achondroplasia is on endochondral bone growth. Well, your spine grows by endochondral bone growth, the end plates of each vertebra. So why, when you are sitting with your friends, do you look at them eye to eye most of the time?
Because our spines are...
Your spine's normal height, average height. And so it's not, we don't understand the growth in achondroplasia perfectly at this time. And so, because as we all know, the majority of the height is lost in the extremities.
Mm-hmm.
So that will probably become clear as we see the evolution from growth stimulation.
Someone asks, Dr. Will, you mentioned earlier, he's Canadian. Are you able to say anything about limb lengthening procedure in Canada? It appears most of the success stories are here in the United States.
You know, I started my career, I was trained very thoroughly. The areas I was involved in was the spine and extremity alignment and lengthening. And, you know, I think the problem in Canada, there's some very capable people in Canada, but they don't have the same experience as the groups in the United States. We talked about West Palm Beach or Baltimore, New York. They are experience centers with very well established rehab programs, and I think their results are better in the continent here. In Europe, there are other good systems as well, but I think one of the biggest differences between Canada and the US is the resources for people to get high volume experience. I'm not insulting anybody by that comment.
Kind of steering more towards the, oh, hang on. I had another question written out. Okay, well, I had an orthopedic question, but I'll ask this one that just got submitted to the Q&A first. You stated that some children don't respond to Voxogo, even that gender can play a role. Are you seeing a response difference with certain ethnicities? That's a tough one. Or I mean, it's a good one, but that's a tough question.
Well, it's a great question. I don't know the answer to the question. I don't think it's been used enough in ethnic populations to know the answer to that question. Yes, I mean, you know, if the average is 1.5, there's some people down close to 0 and some people up close to 3, you know.
Right.
That's reality.
So going to more, you know, your orthopedic background, when correcting bowing for, so this is total orthopedic question that we can get onto. When correcting bowing for achondroplasia, how and when is it determined if to use internal 8 plates or external fixator devices is best for the correction?
That's a great question. Hopkins, our institution at DuPont, the Madison group, and the group in Texas at Baylor, we put together 1,400 patients in a red cap multi-center trial. And we've looked historically at that information and then are doing some work towards the future prospectively. So if you look at that group of 1,400 people with achondroplasia, about 25% of them needed limb alignment procedures. And you can imagine that the majority of those from 20 years ago and before were osteotomies. And they were usually osteotomies which were then held with a plate or pins or a cast. And I basically don't do that anymore. Every single child who has growth potential, we're using growth modulation for. Now, there are a few kids with such severe deformity, even in those under age 10, that they don't respond to growth modulation, but that is an extremely rare event. So the majority of the kids in the growing years are getting growth modulation with 8 plates or whatever device you want to call them. And later on, it depends on the degree of the deformity. If it's a very severe multi-level deformity, we often use external fixators. If it's a milder deformity that can be corrected at one part in the bone, we'll use a plate that screws, internal plate that screws. And then if it's getting lengthening, it can be corrected during the lengthening.
Someone had submitted that my son is 12 and his legs are bowing. This kind of, I guess, was just answered, but is there any therapy, I'm assuming he means Voxogo, that he would benefit from? And if not, what else can and should we do? And I know that kind of goes along with another question that we had, which was, is it worth, so I guess this is kind of orthopedic and Voxogo related. because another one was, is it worth it for a 13-year-old boy to, if they wanted to start Voxogo, should they, given, you know, how many few years of growth that they had left, and, you know, what impact maybe would it have?
Oh, I would like to see you in that room, both parents of that 13-year-old, and tell them no. Because potentially, if it's a boy, he has 3 years of growth or close to it remaining. A girl, less, of course. But they are anxious. If they're looking into using the drug and they want to create height in their child, they're willing to even try it for 2 years. And so that has been our experience here. There's been a number of people who were in their early teenage years or mid-teenage years, 12 and 13, who had been started on the drug because they chose to try it. But you're right, the potentials for gain become rapidly less as you get into that age group, and it becomes difficult. You know, it might be that previous question didn't have anything to do with Voxogo. It might, because there are people who think that physical therapy helps. True. There is absolutely no evidence there whatsoever. That it helps.
And just knowing, just to kind of give like my personal experience, even though we're not here to talk about me, but I just know for girls, especially when I was going through my own orthopedic treatment, I had trouble with my own bone consolidation. I was older than typical, you know, going through lengthening, but they said, you know, my reason for the bone, or the reason that my bones were taking so long to heal, was given that I was an older female, and girls tend to, I guess, heal or consolidate, however we want to say it, more slower than males. And so I wonder if that's like anything to take into, you know, when.
How old were you when you went through the lengthening?
I was 16. So that one, that I had 2 leg lengthenings. My first one was 16, which I healed pretty well with that one, but I was 19 when I had my second one. So I only had about 2.5 years between the two. And so I'm sure maybe that played a role in it. I'm not sure. But then I was 19, turned 20, I believe, during my second lengthening. And so they were just, I felt like the waiting game was just for my bones to heal.
So one of the few studies that's looked at bone formation in older people undergoing lengthening, that cutoff is around 18 to 20. That's when things start changing. The bone formation is not as good. And then the fact you had a shorter interval between your lengthening as well.
Yeah.
You were demineralized a little bit at that point.
Yeah.
So, you know, there are a lot of factors there, but
I just remember I know there were at least like 3 male patients, one with hypo. We kind of were like on the same schedule of when we had surgery, and what, like, versus like stopping turns and everything, and he literally like consolidated so quickly and everything, and I was just so jealous of it. I was like, why am I a female at this moment? All right. Huh?
You still feel that way?
Yeah, right. All right, so we got 2 new questions. Is there any evidence?
I want to go back to a previous question. There was
Okay. That's great.
Suddenly occurred to me was the facial characteristics of achondroplasia. Do we expect they will be affected by Voxogo? And we don't know the answer to that question, but we do know that the growth at the base of the skull is related to endochondral bone formation and closure of some growth plates there. So I think a really cool thing that I'm hoping for my patients is that if you use Voxogo and the base of the skull grows better, not only do you get less foramen magnum compression, but you have a bigger nasal pharynx. So you get away from the obstructive pulmonary disease. And so I think there's huge potential in that area because that for older individuals with achondroplasia, that's a big problem. And so might deal with some of the CPAP issues that are.
Cool. Well, that's good to know. So our 2 new questions. Is there any evidence of medical improvements with any of the drug treatments besides extra height?
Well, we just talked about a couple, right? Spinal stenosis, theoretically, obstructive apnea, maybe less otitis media and deafness. Just trying to think of other things that would be effective. Height and growth. Those are 3.
And then the next one, my 9-year-old daughter had 8-plate surgery in both knees and ankles. Is there a concern with the hardware still being in her knees and ankles and participating in Voxogo therapy?
So does this individual's child, are they still undergoing correction with growth?
I have no idea, but if they want to let us know in the chat.
So this is this is a really interesting issue, and I'm glad you brought it up. So if you're using growth modulation or 8 plates to correct the leg, and then suddenly you speed up growth, you're expecting the correction to be completed quicker. So you've got to keep a really close eye on alignment so you don't overcorrect.
Mm-hmm.
And but in terms of, is there a contraindication? I don't think there'd be a contraindication, but you'd want to watch pretty darn closely.
The person did. I don't want to say the name, just given confidentiality, but it's in the chat if you want to see it. But they said that yes, she is your patient, so I guess she is currently going through treatment.
There you go. So hopefully I give her the same answer in the clinic. Yes, it's not a problem. Should not be a problem.
All right. Well, good. If anyone has any more questions, because we've been on for about 45 minutes now, submit them. But other than that, I don't know if we have any.
Well, those were a good amount of questions.
I know this was a good one. Can I ask Dr. Mackenzie, just knowing, what's the future like for you? Like what, plans? I had actually an introduction question at the beginning that I meant to ask as a secondary question, but we didn't get into it. But hang on, I have to go back to it. Or I guess you did. It was, kind of like how it's evolved. And I know you're the chair of the LPA-MAB. I believe you mentioned that, but I don't know. I've heard rumors that maybe are you?
It's a natural evolution, right? When you do complex, risky surgery over many, many, many years, it's time to move on and play with your grandchildren, right?
Oh, it's time to be grandpa.
And so I'm looking forward to that. I'm planning retirement near the end of this year, but I will still be present in the clinics and help out. But I think that one of the things I'm very, very proud of is that I have such an amazing team around. We have, every time we meet on Thursday morning, the room is jammed. There's 20, 25 people there, and it's genetics, it's orthopedics, it's neurosurgery, and pulmonary, and radiology, and anesthesia, and research, and rehab, and physical therapists. It's just, I find it absolutely remarkable where we've come in the last many years. And so what you want in any system is that it doesn't die when someone retires, right?
Right.
We have great succession plans in place. We've got 2 geneticists, and I have, as you know, I have Stuart coming behind me, and we have great support in our system. So I hope it doesn't make a difference to the care of patients. You know, it's a natural transition, and I should be no different. People don't want to see me when I'm 80 sitting here.
Well, we will definitely have to have you back, whether it's later in the year, before the end of the year, or even after the end of the year. I think it would be fun to maybe have both you and Stuart on together. Maybe we can get like a father-son, you know, dynamic Q&A. That might be fun to do.
We might argue too much.
It might be fun. We could do an 𝘾𝙊𝙉𝙑𝙀𝙗𝑆 family feud. That's what we'll do.
There you go. Not too much of that. He's a pretty sensible person.
So we did get 2 more, and I'll let these be our last 2 questions. Are you seeing any improvements with lower doses and those with the Voxogo trials?
You mean lower than 15 mics?
I guess. Are you seeing? Yeah.
Well,
Mhm.
people. So here's the issue, right? The FDA approved a certain dosing regimen. Now, I could write a prescription and write for more, but again, it is off-label. So the theory, it's kind of interesting actually. So if you have a child who is not responding as you might expect, is it worth using a larger dose? And we don't know the answer to that question. So I think that was what that question was probably directed at.
I think you may have misheard me. Sorry. The question was, are you seeing improvements with lower doses, like the lower sway back?
Differences? You mean less sway back, less kind?
Yeah, I think that's what they were asking. Not about dosage. They were asking about lower doses in the back.
Oh, I see. No.
But I liked that answer about the dosage, even though I didn't ask it, but that was good. But it was, are you seeing improvements in lower doses from those who are taking Voxogo? But someone did just say that the dosage question was very useful. So thank you for that.
Great. Okay.
And then the next question was, how do us parents promote more research for achondroplasia and other types of dwarfism?
Think about the number of people in this world with achondroplasia versus those with 𝘾𝙊 or other more rare disorders. So in the 𝘾𝙊, I just talked to a family today for a while. They were asking me some questions about their child that has 𝘾𝙊 syndrome. And this mother was on several boards. She's involved in the MPS Society. She helped fund Shunji Tamatsu, who's doing his work on 𝘾𝙊 at our institution. And the amount of research funding that has gone into 𝘾𝙊 is very significant. But it's not, most of the, now, excuse me, I know that there have been many private individuals that have helped fund certain aspects of 𝘾𝙀𝙀, you know, the funding for the Clarity study, and it's partly industry and partly supported by the clinic at Hopkins. But, you know, I don't know of too many parent groups like the MPS Society where money is raised and funneled into research. And I think it's a tremendous opportunity.
Mm-hmm. Well, good. They said thank you. So good. Well, if there are no more questions from anyone, I think that was it. I think that was kind of a good question.
Actually, we skipped over poor Munira and her husband, who've done a great job with Growing Stronger support. Actually, so this is another interesting idea. Munira can comment herself, but they've done a lot of work supporting, for example, the Skeletal Dysplasia Management Consortium, and giving small grants to all sorts of systems. But I think what that question was related to was you know, serious mega research.
Mm-hmm.
And I think there's opportunity there.
Yeah. Yeah, I think we're definitely in a new era or new time, however we want to say it, for skeletal dysplasia as a whole, I would say. Munira has posted in the chat, she said, thank you, Dr. Mackenzie. But yes, so thank you for joining us. If there are no more questions from anyone, we have kept you for almost an hour now. This might be our longest episode that we've had. So thank you for that, Dr. Mackenzie. You were very entertaining. We knew this was going to be a good one because you always, you know, you're just a fun person to have a conversation with. You always have a lot of, I enjoy our conversations all the time. And so thank you. And I am very proactive that I think we should have a Family Feud style episode, maybe with you and Stuart or somebody else from the Nemours team, or maybe another skeletal dysplasia practice. We could maybe have a fun game with you guys in the future. But other than that, thank you so much, not only for joining us today, but just for everything that you've done for individuals and their families with achondroplasia and skeletal dysplasia over, you know, your whole career. You have truly, I know, have just made such an impact on so many people's lives. And so I want us to make sure we say thank you for that, in addition to thank you for joining us today. So thank you, Dr. Mackenzie.
Very, very much. It's been a great honor caring for all these families and their children, and thanks for keeping the conversation going.
Thank you. Thank you. And again, we will let anyone know if we have Dr. Mackenzie come back for future episodes. We will let everyone know. So I think we'll end on that note. So thanks.
Thank you. Thanks for having me. Bye, everyone.
Bye.